Good afternoon, everyone. We're just waiting to let the group populate for just another few seconds, and then we'll get started with the presentation today. So good afternoon, everyone, and welcome. My name is John Constantino. I'm a child psychiatrist and director of the Division of Child Psychiatry at Washington U and at St. Louis Children's Hospital. And I'm delighted to introduce a fellow child psychiatrist, Dr. Kevin Simon, to lead today's special forum in recognition of Black History Month. I'd like to begin today's program by acknowledging that we gather today on the ancestral lands of the Osage, Miami, and Sioux peoples who were removed unjustly from these lands, and that we in this community are the beneficiaries of that removal. We honor them as we live, work, and study here at Washington University School of Medicine. And as any native Missourian like myself knows, the natural places of our state are a magnificent reflection of their stewardship. I'd first like to explain the format for today's session. Dr. Simon's talk will last about 40 minutes. Following his talk, there will be a panel discussion followed by an audience Q&A. And we encourage you to participate by asking questions at any time by typing in the Q&A box. The webinar is being recorded. On our panel today, we are very lucky to have Dr. Ericka Hayes of our School of Medicine, Dr. Sean Joe and Hussein Latif of our School of Social Work. And we are also very pleased to welcome into the conversation Adam Lane, who is a member of the St. Louis Public School Board. Dr. Hetty Lee is going to give a specific introduction to Dr. Simon, but what I want to just say as an introductory remark today and from a personal perspective, and really in relation to this month of connection with history, I just can't imagine a more timely or a more fitting presentation for our institution and its community than Kevin's appearance here today. His appearance epitomizes to me the essence of what I would consider necessary connection. And Kevin, by that, I'm not referring to you reaching out 2 hours ago to remind us that you needed the Zoom link. No, to try and encapsulate what I mean by necessary connection, here's my one sentence synopsis of your being with us today. An early stage physician scientist breaks the barrier of the highest impact journal in medicine to tell the tale of systemic mismanagement of the care of Black boys with presumed psychiatric symptoms. This galvanizes the reflection of a senior pediatrician at the zenith of his career, our dean, who reaches out to the leadership of the Department of Psychiatry with an immediate communication that I will paraphrase this way. Who is this guy? And this is exactly, poignantly, what needed to be said. And what are we going to do? Even those at Washington University and Dr. Simon's field who are engaged in the mental health support of Black boys and their families were not fully aware of his work and advocacy. So the article itself forged that necessary connection, which then prompted conversations between the medical school, the Center for the Study of Race, Ethnicity, and Equity at our school, the Brown School, and the Department of Anthropology and Department of African and African American Studies and the School of Arts and Sciences, to connect those four corners of our university in a joint decision to co-sponsor this event and beg Kevin to visit us virtually. Only to find out that when we do contact him, that he was right here with us in the 20-teens when he went to medical school across the river at SIU, and while his wife, Brittany Halford, completed her medicine residency here at Washington University. That was my one sentence. Kevin and his wife count several of our distinguished faculty among their friends from that period, Doctors Will Ross, Eric Lenz, and Jesse Gold. Therefore, even more dots to connect. Kevin, on behalf of all of us, thank you for the work that has riveted national attention to the matter at hand today, and for reconnecting today to our university and city, beginning with your presentation here. I'll now turn it over to Dr. Lee to make a formal introduction.
Hi, my name is Hetty Lee, and I co-direct the Center for the Study of Race, Ethnicity, and Equity with Adrian Davis. And I'm also a professor of sociology at Washington University. And so the Center for the Study of Race, Ethnicity, and Equity is delighted to be partnering with the Office of the Dean of the Medical School the Washington University School of Medicine Office of Diversity and Inclusion, the Department of Psychiatry, the Department of African and African American Studies, and the Department of Anthropology in hosting this evening's event. So as John said, you have support from all corners of the university. We're delighted to welcome Dr. Kevin M. Simon to Washington University. Black men are among the most vulnerable to systematic racism in all of its forms. The educational, employment, justice, and health systems all routinely fail them. Black men routinely find themselves on the negative side of acute disparities, including in policing, incarceration, and myriad forms of violence. These disparities start with Black boyhood and progress into a near uninterruptible school to prison pipeline. To envision a different path forward, one that envisions Black boys as future citizens, we need the best and most innovative minds. Dr. Kevin Simon is one of those minds. Dr. Simon starts his important article, Them and Me, the Care and Treatment of Black Boys in America, with the following, and I quote, "As I complete dual fellowships in child and adolescent psychiatry and addiction medicine, honing my expertise in diagnosing and treating disorders of thinking, feeling, and behavior affecting children, adolescents, and their families, I have seen patients with a wide range of disorders. Embedded in this seemingly descriptive phrase are two words we rarely hear in the discussion of Black boys, thinking and feeling. Dr. Simon's work invites us to shift how we approach Black boys, to center their thinking and feeling, and to ask whether the aberrations are them or society that all too readily pathologizes them. I commend to you his short but poignant article as it integrates case studies and narratives to articulate a new mode of care for Black boys." Dr. Simon is a board-certified psychiatrist currently completing dual fellowships in child and adolescent psychiatry and addiction medicine at Boston Children's Hospital and Harvard Medical School. He completed a general psychiatry residency in the Department of Psychiatry and Behavioral Sciences at Morehouse School of Medicine after graduating from SIU School of Medicine. His research already has been recognized nationally. He has received research support from the American Psychiatric Association, the American Academy of Child and Adolescent Psychiatry, the National Institute of Mental Health, the National Institute of Drug Abuse, and the Substance Abuse and Mental Health Services Administration. His path-breaking work on inequity, race, social determinants, and substance use has been published in the New England Journal of Medicine, Health Equity, Health Affairs, Psychiatric Services, Psychiatric Times, Current Psychiatry, and Child and Adolescent Psychiatric Clinics. He also regularly presents at national conferences and has been featured on ABC News, Forbes, and NPR. So please join me in welcoming Dr. Kevin Simon.
Thank you for having me. Almost don't even recognize that it's me you guys are talking about. So what I'm going to do is share my screen, and I believe now you're looking at a screen that says Them and Me, Black Boys, Mental Health. And yeah, I am Kevin. You can call me Kevin or Dr. Simon. And thank you to all the offices of the school, Office of the Dean, the African American Studies, Center for Studies on Race, Equity, and John for reaching out via email. And yes, I fondly remember the Central West End and driving an hour and a half quite often to see my wife as I was finishing training. So what I'd like to do today is first talk about my disclosures. So one, I am obviously a Black male. That's my daughter, Brooke. She likes to make sure that I disclose any kinds of funds that I have. And so for this year, within my addiction medicine fellowship, I am receiving a grant from SAMHSA, which is aptly named REACH, Recognizing and Eliminating Disparities in Addiction Through Culturally Informed Healthcare. And that's through the Yale School of Medicine, even though I am myself at Boston Children's Hospital and Harvard Medical School. The agenda today is we're going to use some mediums of narrative, and the narratives will reflect Black boys. But first, we have to talk about normal developmental expectations of children. And then we're going to see the Black boy experience through academic literature. And then we're going to think about how can we actually dismantle some of these unjust systems and promote health equity and justice in your clinical space at WashU and anywhere else anyone is listening, as well as schools and other forums. And so we're going to use Between the World and Me, and the person that you're looking at is Ta-Nehisi Coates, who penned this, one can't really call it a memoir. It's a letter or essays to his son, describing his own personal journey through the city of Baltimore and beyond. And for myself reading it, there were a number of things that resonated with me as I was reading it, both thinking as a father and then thinking of, the kid who grew up in Brooklyn, New York, went to Catholic schools, walked on bus routes, trains in the city of New York, and how everything that he was writing, I had experienced. And there are a lot of other narratives, whether that's Notes of Anita's Son, if we're talking about James Baldwin, Invisible Man, the list of authors that at least I think child psychiatrists or psychiatrists should read to kind of get a lens into the Black mental health are wide. But we're going to focus on Between the World and Me. And so that's the book. And so the first quote from the book is, "I am not a cynic. I love you and I love the world, and I love it more with every new inch I discover. But you are a Black boy, and you must be responsible for your body in a way that others cannot know." And so I'm a psychiatrist, so undoubtedly there are often times I get presented with consultation or referrals for Black boys and other children. And it's really my own experiences described in the book and others that help me to see patients more holistically rather than just simply relying on sets of criteria that are organized in a fashion in our DSM-5 or diagnostic statistical manual that most psychiatrists undoubtedly have in their office. I have one too. So we have to talk about normal developmental context for Black boys. And so when we go back to infancy and toddlerhood, what are we expecting? And that is the development of critical neural pathways that lead to linguistic, cognitive, and social-emotional capacities. And really, it's for infants to gain trust from a warm and responsive environment. So there are times when I'm in the hospital and I am actually getting consulted on a 2-year-old. And when I'm talking with parents, I am really emphasizing that second bullet. The best thing that you can possibly do for your son or for your daughter is to create a trusting environment. So, and that's for all kids, and all kids should be getting this, but unfortunately, as we're going to see, some of us are not. If we then think about early childhood, well, what's supposed to happen? Formation of peer relationships, gender identification, the development of a sense of right and wrong. Should be learning your language or languages, gaining a sense of self, greater independence, and beginning to learn the workings of the world. That's you should be able to go outside, you should be able to go to the park, you should be able to make mistakes because you're supposed to be learning. Wait, what is this thing called? Growing up. When we transition to middle childhood, then this is classically where parents really get frustrated because there's a growing peer orientation, right? So I want to be with my friends more than potentially I want to be home. And the world becomes one of learning and testing critical skills and assessing one's abilities, right? So this is the risk-taking behaviors that you might see in some kids. And undoubtedly, like white children, like Hispanic children, like Asian children, right? Black children are going to want to test the waters about what is it that they can or cannot do. And then now when we think about adolescence, and so we're thinking about teenage and adolescence now, classically is thought to end supposedly at 25. I sometimes think I'm still in adolescence, is a search for identity may result in bizarre and contradictory behavior as they try to reconcile who they want to become with what is socially desirable. And then concern about normalcy, variable moods, low self-esteem are common, right? I could easily phrase this to say, contradictory behavior. You're still in fellowship. Don't you want to end fellowship, right? So this is to say there are things, again, that are normal that sometimes we don't really allow our Black boys to experience. Now, where does this all begin? Technically, I could show you data about disparities with regards to maternal care for Black mothers, infant outcomes when Black pediatricians are paired with Black patients. But I'm going to start at the educational level. And the first thing I'd like to do is share this video, and you shall hear it. We've tested it.
There's a new study out of the Yale Child Study Center that I had to read a few times just to believe what it was telling me. The researchers recruited about 135 preschool teachers. They had them watch video footage of 4 kids playing: a Black boy, a Black girl, a white boy, and a white girl. And they told the teachers, their subjects, watch the video, there may be some challenging behaviors. As soon as you see something that could become challenging, hit the enter key on your keypad. Well, here's the trick. There was no challenging behavior. The researchers were using eye scan technology to see which child the teachers were looking at the most. And what they found is that the teachers, both white and Black alike, spent the most time watching the Black boy, waiting for bad behavior that never came. There's one more really interesting headline in this study, which comes later. The teachers were also given a 1-paragraph description to read of a hypothetical child with a stereotypical name who behaves pretty badly in class, pushes, scratches, throws toys. And some of the teachers were also given some biographical information that helped make sense of that behavior. They were told that the child lives with his mother, father has been in and out for years, they're relatively poor, the mother is depressed, works 3 jobs. Researchers wanted to know if knowing this information made the teachers more empathetic to the kid. Well, here's the shock. It did, but only if the teacher and the child were of the same race. If the teacher and the child, a white teacher and a Black child, or even a Black teacher and a white child, knowing that biographical information, those teachers were less empathetic towards those students. And here's why this matters. Imagine if this is true, if there's this empathy deficit in preschool, well, imagine where else that's true.
So, thinking about where else that is true, and looking at this preschool data slide that I have up, Black students make up 18% of preschool enrollment. And again, we're talking about preschool. Yet Black students make up 42% of those who are suspended once. Again, this is preschool. And then there's 48% for those that are suspended more than once. And this is important because he mentioned the study noted if you read the paragraph that they gave you, you could become more or potentially less empathetic based on what you read. And, reading the study myself, I thought about, I often read a paragraph prior to seeing patients. It's called the chief complaint, or and I get a paragraph when I'm on a call, and it makes me pause to think more critically about the information that I'm hearing. And as we're going to see, we have to think again more holistically about the presentations that, at least as providers, people suggest. So it is not uncommon for me to hear of a 5-year-old Black boy who has been suspended a few times, supposedly truant from school, and there's a question about, is this oppositional defiant disorder, or conduct disorder, or DMDD, a whole host of alphabet soup. And I pause myself to not immediately reflect and say, oh yes, this is what they say it is, and want to take a more holistic picture. But the data doesn't end there. So when we think about grade school, and this is for both Black girls and Black boys, but we're talking about boys here. By 10 years old, there's evidence to suggest, and there's a really good paper, The Essence of Innocence, that says Black kids are viewed as less innocent by 10 years old. Black kids are also then thought to be older at about 10 years old. And by a range of 5 years, right? So obviously we're talking about a range here. So that means some people would have looked at a 10-year-old and said, oh, you know, he's 16. Or a Black girl, oh, she must be 16, or she must be 15. And that has a lot of significant potential impact in how, again, grade school, so we're talking about, you know, 5th, 6th, 7th, 8th grade, you should be able to, yeah, I'm from Brooklyn, take the train, go to the bodega, go to the pizza store, be in the park, and be exploring, again, remember the normative behavior, be exploring the world and exploring what you should be doing. Yet if I am viewed as 5 years older than I actually am, because most 11-year-olds do not carry around a wallet and have their ID, right? When I now engage with someone and I'm acting, quote unquote, a certain way, that person is going to perceive it as, oh, this person is trying to potentially be defined or is trying to, you know, not listen to what I'm trying to say. But again, the reality is they might be just 10 and not really understanding the social context of what's going on. Another important fact is this last bullet point. There's less than 2% of teachers, preschool, grade school, high school, are Black males. And why is this particularly important? This is important because there's evidence to suggest if there is one Black male in a Black student's life, that increases the odds that they'll graduate. So we have to think about this very holistically in terms of all of the pipelines that are leaky. And so it's not just a matter of, oh, we need to get more Black males to become physicians. We need to get more Black males to be teachers. As we move along to high school, so nationally, Black males, 59% graduate high school. That is the lowest rate of all races. And yes, race is a social construct, but it is the construct that we have right now, so I'm using it. Students of color are often concentrated in lower resource areas. And so I'm talking to folks in, you know, Missouri, specifically St. Louis, and I know that you all know the differences in resource allocation for those families that live in the Central West End versus other aspects and communities in St. Louis. And so we come to find out that schools with 90% or more students of color spend almost $1,000 less per student per year than those that have 90% more white students. And again, resource allocation, yet another way that we need to improve our system. Next quote, I feared not just the violence of this world, but the rules designed to protect you from it. The rules that would have you contort your body to address the block and contort again to be taken seriously by colleagues and contort again so as not to give the police a reason. This line is akin to the idea of code switching, right? So Kevin or Dr. Simon has to really act a certain way, unfortunately, when I'm driving. And I can tell you that, oh, I won't tell you how old I am, but since I've gotten my license, every year I've been stopped by a cop, every year, without fail. And in 2011, medical student at SIU, Southern Illinois University in Springfield, Illinois, hour and a half away from you guys. I'm back in New York for a holiday. I'm in a park with my friends. And again, at this point, I'm older than 20. And we're in my car, no marijuana, no tobacco, no substances, just guys hanging out. And I get pulled over, and I'm the driver. So I get pulled over. License is up to date, registration is up to date. It's my parents' car. Yet I'm asked to step out the car. I'm asked to put my hands behind my back. I'm asked to step in or sit in the officer's car. And I'm brought to, I was at Queens at this time. I was brought to Queens Precinct. To this day, a decade later, I have no clue why I was arrested, no clue why I sat in a jail cell for 6 hours because they were supposedly clarifying some things with Albany, the capital of New York. And then I was told, oh, you have to come back to pay this fine in February. Mind you, this is a first-year medical student. I had other things to be stressing me out, yet here it is. I'm arrested randomly. But fortunately, I didn't quote unquote arrest, didn't resist, I should say. My parents were quite accommodating. This, Kev will bring you. Yet that's something that happens quite often, and there's no Instagram or anything that recorded me. But it did happen, and it happens to a lot of people that look like me. So now we're going to talk about Black boys and the injustice system by the numbers.
Mass incarceration means that we've got a very high rate of incarceration historically, comparatively. And the other thing is the rate of incarceration is so high, so socially concentrated, that we're no longer incarcerating the individual, but we're incarcerating whole social groups. The rate of incarceration now is about 5 times higher than it was historically. Historically, it was 100 per 100,000. Now it's about 500 per 100,000. If we look at prison, if we add jail to that, it's about 700 per 100,000. Nowhere in the world incarcerates as much as we do. We've seen extremely high rates of exposure to the criminal justice system for African American men with very low levels of schooling. So if we think about Black men who were born in the late 1970s and who are growing up through the American prison boom of the 1980s and the 1990s, the chances that they're going to serve time in state or federal prison if they dropped out of high school is about 70%. So going to prison for that group of Black men with very low levels of schooling, that's become a normal life event. And that's really only happened in the last 10 years. We're at this point now where there's about 1.2 million African American children with a parent who's incarcerated. That's about 1 in 9. The research shows that kids who experience parental incarceration have diminished school achievement, they have behavioral problems, depressive symptoms, acting out. And there's also evidence that these kinds of negative effects associated with parental incarceration are concentrated more among boys than among girls. And there's a very real risk here that incarceration becomes an inherited trait. The underlying issue is we've chosen prison as a way to respond to that problem of crime. And there are a whole variety of ways that we could have chosen to respond to that problem of crime. We've chosen the response of the deprivation of liberty. And we've chosen the response of the deprivation of liberty for a historically aggrieved group whose liberty in the United States was never firmly established to begin with.
So when we look at youth incarceration, Black boys 10 to 17 make up 44% of the population. Yet again, Black children are about 16% of children in the nation. And Black youth are 4 times as likely to be incarcerated. And in the state that I'm in, Massachusetts, it's 10 times as likely. So when we look at the studies, it's to say out of 100,000 youth, 222 Black youth will be arrested or incarcerated versus just 22. I looked up the data in Missouri. It's actually, you guys are in the national range of just the 4 times as likely, but still 4 times as likely is 4 times too much. And looking at the juvenile justice information, it's highly concentrated in the St. Louis and Kansas City areas, just for those who wanted to know. Now, he mentions in the clip that we just saw, those that don't graduate high school. So again, it goes back to that 2% of teachers are not, or there's only less than 2% of teachers being Black males, which is why that's highly important. Yet we can't just say, oh, well, this is an economic issue, because when we look at this particular graph, which is from colleagues here, the sons of Black families from the top 1% had the same chance as being incarcerated on a given day as the sons of white families earning $36,000, right? So it's to say it does not matter what you look like, what you dress like. There's a very good chance that you're going to be incarcerated. Legitimately, now, the reason that I think, despite still getting stopped, I got stopped in February of last year. I have this badge. This badge says doctor on it. And I'm, happy that I have a badge. However, I'd much prefer just being able to be myself and not have some label to be able to help the officer assuage his own anxiety of, oh, sorry, sir, you must be going to work. I could have been going to the ice cream store. You didn't have any reason to stop me. And if you did, despite me having a badge, I would prefer the ticket if I was speeding. I would prefer the warning. But the fact that you're not giving it to me implies, well, there was no real infraction, was there? So this is something, again, that's happening all too often to our Black persons. Black people love their children with a kind of obsession. You are all we have, and you come to us endangered. So we're going to really think about Black mental health here. And this is my last clip, I promise.
This is so intricate.
Trey Lee says for years he struggled with depression.
I would have this impulse to get that knife, and I would be like so tempted to just put it right through me and end it all.
At 13, he attempted suicide.
I just noticed my arm was bleeding. I noticed I had a knife in my hand, and I didn't know what in the world I was doing.
Trey's battle is a reality for far too many children, especially Blacks. A recent study shows suicide rates for Black children aged 5 to 12 were 2 times higher than white kids of the same age. Kathy Williams has made it her mission to help.
I will not stop, and especially in the Black community, because we don't think it happens to us.
And that pain is just as powerful today as it was in 19.
That's Torian.
Her only child, Torian, was an all-American kid, an honor student who played the saxophone in the church band and loved basketball.
He was 15.
He was clowning around on his bicycle the day before she found him dead at home from a self-inflicted gunshot wound.
I saw moodiness. I saw irritability, but we were not looking at it that way. We were looking at these signs as being typical teenage behavior.
But doctors warn these can be typical signs of depression.
What you're looking for is a number of those symptoms clustering together over a 2 or 3 week period. And so if you keep seeing it, maybe this is something we need to go get some help for.
Yet research shows Black and Hispanic children are less likely to get mental health care than white kids.
Education and career, if that stresses you, stand up.
Now 16, Trey meets with a support group in Durham, North Carolina, focused on breaking the silence about suicide in the Black community.
Black folk would not talk about if somebody died by suicide. It was like it was a shame. They would sweep it under the rug.
99% of me want to die, but that 1% of me said, no, you can handle this.
We all need somebody to lean on. And
This is
So in reference to the study that they're referring to, there's actually 2 data points. So this is the 1993 to 2012. And you can see here, thinking about around the 2000 timeline, that all of a sudden the rate for Black boy suicide surpassed that of white boys. And the next slide, I think I find this particularly jarring, is when we look at the method of completion. So we're talking about hanging and suffocation. So in the video, she did mention that her son, unfortunately, had shot himself. But firearms are actually, they happen much less often. And if you think about the age range that we're talking about, children, it would make sense. It's very important for my pediatric ER colleagues and child psychiatrists who see kids in ED. When you're hearing about the stress and suicidal ideation or a suicidal gesture or an attempt, right? We really need to understand the context and what was the method, because here it is, hanging is actually most common. However, oftentimes when I'm talking to groups or pre-pandemic talking to people, they wouldn't think hanging and suffocation was the leading cause by a wide margin. Um, and it's also jarring for me to think, if we go back, Jim Crow, back even further, right? Hanging and lynching was the method in which to kill Black men. And so that idea of this intergenerational trauma, that I have thoughts about this, and so unfortunately we can't postmortemly inquire why did someone choose this method, but it's very important to be cognizant about this. Now, I'm going to shift a bit, and here's John's paper, Dr. Constantino, and timing of the diagnosis of autism. This is very important to me because I often see kids who, when I see them, I'm like, I think there's a neurodevelopmental condition going on here. And it has not, it on 3 occasions of while during fellowship, I've had kids who are nearing 10, 11 years old, and parents present to me and how I'm engaging with the boy. I'm like, I think I need a consult here in terms of we should get some neuropsych testing. Now, granted, autism is a clinical diagnosis, so I have a strong suspicion that there's some social communication pragmatic issues going on, repetitiveness, but again, because of the Black skin that the boy had, others couldn't see what was right in front of them, which was this is a boy who has difficulty with social reciprocity. This is why he can't necessarily quote unquote hear you and follow your directions. He really does have cognitive rigidity. He likes certain things. So if you take away said thing from him, he gets really emotionally dysregulated, right? Putting just context to the behavior then says, oh, okay, this is actually autism. So John's group saw, well, the diagnosis is often made around 5 years old, yet almost a 3-year potential delay for when parents brought up the concern. And so the patients that I've had, I think to myself, wait a minute, you're 10, you're 11. You've undoubtedly seen people before me. You've been in schools before you saw me. Your pediatrician has seen you. Yet again, how is it that you're seeing the child? And so I think often it's dismissed, and we know with regards to literature on autism, well, what's the best benefit? Early intervention, right? So yes, did I get those kids services? Yes. A decade or let's say 5 years too late, potentially. They got them now, but the fact of the matter is I just suspect if their skin and their hue was a little bit different, then there might have been a different outcome earlier on. Again, also another diagnostic clarification issue here. So racial and ethnic disparities in ADHD, far less often diagnosed for Black kids, particularly Black boys. But what's more diagnosed, again, the whole slew of behavioral dysregulation, again, DMDD, conduct disorder, oppositional defiant disorder. And there's a number of papers that highlight this. So oftentimes when I meet patients and families, I have to ask, okay, wait. I know what you're telling me. He doesn't listen. Okay, not listening in school. Now, this is pre-pandemic information I'm talking about. Can you tell me the makeup of the class? Oh, okay, he's one of 2 Black kids in the class. Okay, can you tell me the makeup of the teacher? Oh, okay. The teacher is not race congruent with your son, right? So it's very important, and so I make a lot of phone calls to schools. At least I was, and really saying, wait, there's someone here, and again, whole labels. I say Boston Children's Hospital, and people pay more attention. I say, wait, I think this child might need a 504 plan. Let's not just keep dismissing him or suspending him or sending him home. Let's actually think about, well, what are we missing that could be very helpful? And this is another study, and there are a lot of studies I wanted to choose, but given time constraints, I just selected a couple. This is about race-related traumatic events online and mental health among adolescents of color. Very important paper to me. And so thinking about, well, when was this accepted? 2019, right? If we think about last summer, all the names that we can say that you remember who were killed unarmed, continuously replayed and replayed and replayed and replayed. That has an effect on the kids and adolescents of color, where they do have more depressive symptoms, anxious symptoms, symptoms related to PTSD. And again, this predated the summer that was 2020. So it's very important. So again, when I see patients, I often tell families, you know, like, we just have to have like no screen time sometimes. It's okay, because this happens all too often. And last quote, all my life, I heard people tell their Black boys and Black girls to be twice as good, which is to say, accept half as much. These words would be spoken with a veneer of religious nobility, as though they evidence some unspoken quality, some undetected courage, when in fact, all they evidence was the gun to our head and hand in our pocket. This is how we lost our softness. This is how they steal our right to smile. So thinking about, well, what are strategies, Kevin, to actually reversing some of these things? So on the individual level, if you are someone who practices psychiatry, psychology, if you're just a parent, if you're a friend, acknowledge and affirm kids' feelings. They have feelings. They are not just little people. They really do have emotions, and they should be allowed to have those emotions, particularly Black boys, who are often suggested and told, don't have emotions, just, you know, suck it up, you know, the whole pull yourself up by your bootstraps. Create space for race. I often allow patients of mine, and these are all types of patients, but patients of mine, to talk about what is their experience. And when I say race, I could also say gender. I could also say identity. Often I meet patients whose families are not supportive of their identity. And so for 45 minutes to an hour, well, when you meet Dr. Simon, you be who you want to be. You tell me what you want to tell me. Racial storytelling is very important. Validating, much like affirmation. The process of naming. So this is actually really, really important for my colleagues that have patients who don't look like them, right? The process of naming, and you see in there is a notepad. When we think about what some boys, again, not all, some boys like to do, right? You're going to hear the quote unquote term rap, right? I view that as, you rap all you want and come back and show me what lyrics you wrote, right? What is that? That's journaling, right? Again, just I view it differently than some of my colleagues. So when I hear rap, I actually don't hear, oh, curse word, expletive. If it's there, it's there. If it was in your journal and you curse, that'd be fine with me too, right? So do write about your experience. Do tell me about your experience. I want to see what comes of that, right? External devaluation, trying to block that. Counteract that devaluation, rechanneling rage, again, talking about scholastics. You could talk about academics. You can talk about extracurricular activities. Try to get some of this energy, you know, utilized in some fashion. But that number 5, the process of naming, I can't tell you how often I've heard, oh, you know, he or she's wasting their time. It's like, no. Actually allow them to cultivate this humanistic aspect to them. In reference to kind of broader, not just necessarily with the patient, right? So think about race conscious medicine. And so that's race defined as a social construct. We understand that. Effects of that structural racism should be analyzed, right? Then the consequences of that racism on health should be taught, then supported by overcoming that structural barriers to health, right? So I often will have a parent, and I'll say, your son likely gets suspended more often, and I will bring the evidence to why it's happening. Not just why it's happening because the things that supposedly he is doing in the classroom, but just generally what happens to your son and other boys who look like your son across the nation, right? So, and parents like to be informed because that helps them be better advocates for their child. And hopefully there's a reduction in racial health inequity. Last bit is structural competency. So I highlight this because I think Jonathan went to your med school. And then Dr. Hansen is a friend of mine. Structural competency, they're thinking about what is a new way of the medical system to engage, think about, teach about stigma and inequality. And their 5 points are like key. Screenshot this if you want. Recognizing the structures that shape clinical interactions, right? There's evidence from colleagues across the street from us that published JAMA Psychiatry, rates of restraints in the ED, unsurprising, who got restrained more often, right? Let's think about all our systems, where and how can we improve upon them? Develop an extra clinical language for the structures that are happening that are enforcing these inequities, re-articulating cultural presentations in structural terms, right? So again, if I have a Hispanic, Spanish-speaking family and they're describing certain symptoms to me, you know, can I explain that my logic back to them in ways that they understand? Right? We have to be able to do this. Observing and, you know, imagining structural interventions. So how is WashU's, I believe you guys have a new inpatient unit, right? How are you going to make that unit an environment that is providing care equitably? And then developing structural humility. I don't know everything. I do not pretend to know everything. I ask a lot of questions. Grand rounds, I ask questions. Lectures, I ask questions, right? I'm always trying to understand, how is the system the way that it is? Why is it the way that it is? And sometimes those questions that I have get turned into thoughts that get turned into a paper. So I appreciate the dean saying, who is this guy? I ask myself that question too. So thank you for inviting me to talk about a topic that is near and dear to me, Black boys. And if you want to follow me, you can on Twitter, on Instagram, and you can reach out to me. So again, thank you for sharing this space with me.
Thank you so much. I'm going to, the panel is going to, each panelist will respond to your talk for 5 minutes, but before that, I need to introduce the panelists. So let me go ahead and do that. And I have so many comments and questions, but I'm gonna be fair and do the prepared questions and also listen to all of you who are chiming in with your questions. So first I'd like to introduce Dr. Ericka V. Hayes, who is an associate professor in the Division of Pediatric Infectious Diseases at Washington University School of Medicine and St. Louis Children's Hospital. A native of Mississippi, Dr. Hayes completed a BS in chemical engineering as well as her MD at Washington University. She also serves St. Louis Children's Hospital as part of the infection prevention team for the past 10 years, including as medical director of infection prevention from 2015 to 2020, and currently is associate medical director. Dr. Hayes' clinical and research interests include implementation of successful universal HIV testing programs for adolescents and young adults, STI testing in youth, and acute HIV in youth. Dr. Hayes' other passion is medical education, and she is co-course master of the second-year Pediatrics course at the School of Medicine and directs the didactic portion of infectious disease education for new fellows. Next, I'm going to introduce Dr. Sean Joe, who is the Benjamin E. Youngdahl Professor of Social Development and the Principal Director of the Race and Opportunity Lab at the George Warren Brown School of Social Work. Dr. Joe's research focuses on Black adolescents' mental health service use patterns, the role of religion in Black suicidal behavior, salivary biomarkers for suicidal behavior, and development of father-focused family-based interventions to prevent urban African-American adolescent males from engaging in multiple forms of self-destructive behavior. Next, I want to introduce Dr. Hussein Latif, who is an assistant professor at the Brown School of Social Work. Dr. Latif's research focuses on the role of African-centered approaches, the role of African-centered approaches in improving outcomes of youth prevention programs for African-American youth. He is currently examining the relationship between African-centered constructs and indicators of positive youth development among African-American youth. Finally, introducing Adam Lane, who is an education advocate who has been driving toward educational equity in the city of St. Louis. As a Teach for America Corps member, he taught high school math and in 2014 joined Inspire STL, an education access and support nonprofit supporting St. Louis students in getting access to the best high school and four-year colleges. Adam continues the mission by doing diversity consulting in education and serving as an elected school board member. He currently serves as the executive director of his own nonprofit, the Young Griot Society, which increases youth literacy through creative writing, and works full-time as the deputy chief of staff to the city treasurer. A native of Boston, Adam received his BBA in finance from George Washington University and his MED from the University of Missouri, St. Louis. So thank you, panelists, for being here. And I think we can all go around with your 5-minute responses. And if we want to, we can just follow the order of introduction. So why doesn't Dr. Ericka Hayes go first, then Dr. Joe, Dr. Latif, and then Adam Lane, if that's okay with you.
Okay. Well, thanks so much for the introduction, Dr. Lee, and a huge thank you to Dr. Simon for that talk. So I'm coming to this discussion as a pediatrician, and certainly in all of my pediatric populations, but particularly my HIV population, certainly this entire discussion really rings very, very true. For those who may not be aware, if you look at transmission of HIV in the United States and those who are infected with HIV, it's very disproportionate in that African Americans are very much overrepresented in that population. I think, thinking about the thoughts and the things from the talk that really came to mind is, I often, say to my students that you see what you want to see. And so, we talk a lot in medicine about, don't come into seeing a patient with, a diagnostic certainty. Because if you have an idea of what you think that patient has, guess what? You're going to probably fulfill the prophecy of what it is you think they have, rather than being open to all of the possible diagnoses that are there and all of the evidence and material you're being presented. Because once you kind of lock in on something, you start to disregard the things that doesn't fit the model that you have. And unfortunately, I think as a society, as well as also unfortunately in medicine, we often have that approach when we're dealing with children of color. So especially, once someone has given a child a label, unfortunately, what we often see is that, that label carries through. And it takes, hopefully someone really to take a fresh eye and leave the bias at the door, as Dr. Simon discussed, and really take a fresh look of what's really going on. And so I think that's something we need to stress more and more in training, that, again, just because this was someone's descriptions and thoughts, really to evaluate independently and unbiased and compassionately, as well as from a culturally informed place. To do that is hugely important because, we make, diagnoses and consequences that really impact children's lives and will impact, honestly, their entire life well into adulthood when we're making those sorts of decisions. I also wanted to speak to the point that Dr. Simon talked about with the journaling and really letting them express things and name things. And I think that's incredibly important. So working with my adolescents, there's no tone policing. If they want to use language with me, that's okay, because if that's how they can best express what they want to say to me, that's incredibly important and powerful, and allowing them to really be themselves in a space so that we can communicate honestly is, again, incredibly important. I think I'll stop there. Thank you.
All right, good evening, everyone. Dr. Simon, thank you very much for framing the conversation and for your many points. I think I want to start, again, my training is primarily as a social worker, which began clinically and then has moved into community level interventions. My work centers on Black boys and young men here in the St. Louis region and how we support their economic well-being and social mobility, as well as their general health. I wanted to kind of highlight a few things relative to what you raised around suicidal behavior, and also, of course, the recommendations that you're offering for clinical practice. So regarding suicidal behavior, we understand the experiences that Bridget et al. In their study have identified in terms of the increase in suicide among Black children under the age of 12 brings us into a whole different conversation around the experiences of Black Americans, because we've never seen that level of suicidal behavior, and it's never surpassed that of white children ever in all the work that I've seen, and that's gone back to the earliest of 1908. So this is a totally different experience young Black children are having, and it's now generational. It's a generational specific experience that their rates. But however, over time, we know that younger and younger Black Americans of different ethnic backgrounds have been experiencing higher and higher rates of suicide over time. So in the 1970s, the groups with the highest risk among Black Americans used to be those up until age 45. Now the higher risk are those under 35, and particularly those 20 to 21. And now we're beginning to see, as we saw in the 90s and early 2000s, the 15 to 19-year-old, and now we're seeing the babies, the children who are saying, for whatever reason, life is so painful that it's not worth living. So that calls into question a lot of for us to understand about what that experience is for them, and we should be empathetic. So I appreciate the big message for me, and my response is yes, we have to pay attention to Black boys, and I think I celebrate that, and I think your point was well taken there. I also wanted to respond that as we acknowledge this and the importance of acknowledging Black boys' emotions, one of the critical things that we have to talk about is, again, how we foster notions of masculinity, and that impacts the ability to emote, but also impacts the empathy that we either don't, well, we fail to show Black boys, and particularly the parentification or adultification of Black boys, where often when I began my work here in St. Louis, I kept saying Black boys, but people would have an automatic thought and say Black males or Black men. Even though I'm talking about boys, they will be talking about Black men. So I think you have lifted up the idea, again, that it's very important to understand that they are children, they are boys, and we have to pay attention to them and understand how both we foster their sense of masculinity, and it impacts their mental health, and at the same time, how it impacts clinicians' ability to be empathetic. So your point about empathy deficits, it's not only in the children, but it's also in the clinicians. And to the extent that we have to figure out how to attend to that, how do you train around that? Because of your unique experiences, you have brought your experiences also into your clinical practice. But now how do you pull it out to say, what is it that we do in terms of training future psychiatrists, training future social workers? I think that point is critically important. We don't have the answers, but you again, your conversation points us to the need to do more around that. Then I want to highlight what matters, particularly as we're dealing with suicidal behavior among Black or mental health seeking behavior, mental illness among Black children, particularly Black boys. The point there is, again, family engagement becomes critical, because the literature tells us that Black boys and Black children are more likely to reach out to their family members for support and to discuss those things than being willing to engage in clinical services. So again, not only acknowledging the disparities or the inequality in access and quality of care, but we also have to figure out how to engage families, because family engagement is going to be the way to sustain Black children in care. We know these children tend to drop out sooner. They don't feel the treatment is efficacious or good. They don't like the engagement with when they have to be prescribed medication. Families are concerned. So again, this is very important conversations for us to continue to have, and I appreciate the opportunity to join in this dialogue. And I'll stop there.
I believe I was next. I want to thank you, Dr. Simon, for what has been an excellent presentation. I'm very happy to hear that someone is doing the important work that you're doing and bringing it to our attention within your field of study. I'm coming to this conversation, I think, similarly how you introduced yourself at the beginning. I'm coming to this as a Black man. I'm also coming to this conversation as a Black father of two Black sons, but also in terms of my academic training, I'm coming to this conversation as a social work scholar who has primarily spent his time studying the role of youth developmental theories and what the implications of that work is to bolstering positive outcomes in Black males. So, one of the first things that comes to my mind, when I think or I listen to your excellent presentation, and also after reading your excellent article, is how do we see Black boys? How do we see Black boys? And not in the sense, how do we see them in our what they're doing in their behaviors, but what do we see them on a deep structural level, in their ontology, in their sense of being? And we know that paradigms are so important to this conversation because paradigms set the brackets, the barriers, the limits to thinking about what something is, how do we explain something, and what we do about some type of phenomenon. And I would argue that one thing that we can see very clearly within the context of American history is that Black males, and by consequence, Black boys, have been viewed from a deficit approach. Black boys are not viewed as having an inherent capacity, inherent value, inherent worth, inherent goodness, which is probably the most important variable to this conversation. But why is that important? And I think that's what comes to me as I listen to our conversation, is that it's important because, as I mentioned, it's going to impact the assumptions or the implications of what we can do for that population. And with Black boys, I would argue that at best we've used them as in terms of a reference of where their disparities are and how closely can we get them to the norm, believing that we can never get them to the norm because there's this inherent deficiency anyway. So the best you can do is mitigate something that's already broken. So again, when I think about this conversation, it first, one, requires us to think about how are we coming to the subject of Black boys and their mental health? Do we embrace that they have an inherent goodness? And if we do embrace that inherent goodness, that means that we are also in this conversation have to believe that there's the potential for protective factors, there's the potential for resiliency factors. And ultimately, that also means that we have to believe that the Black community itself has more than trauma to offer us as scholars, as professionals, to think about how we address these issues. So I'll stop there, and I look forward to furthering our conversation with the panel.
Thank you, Dr. Simon, for everything that you've presented to us. We can be so deeply engaged in this work, and still every single time a conversation comes up or a presentation is made, we learn so much more that we didn't know, and that's definitely how I felt today. I'm coming from the lens of, well, from your research in Boston, being a young Black boy who grew up in Boston, and also an educator here in St. Louis, and I really appreciate the lens that you take, the mental health and just health in general, the lens that you've brought to this work and the research that you've done and you've shared about. And being an educator and working in education, it's so easy to see these things play out, but we don't often call it out. I feel like two of the biggest buzzwords or buzz terms in education recently have been trauma-informed care and culturally responsive teaching. But I do feel like those two terms really stop there. It's just the acknowledgement, but we don't acknowledge what our work is in counteracting that. We just say, all right, well, you know, there's trauma there, so just be mindful. And our teachers are just mindful, and our principals are just mindful of that. But we even seldom recognize the part that we play to reinforce these systems as educators. And I think about Black boys when they show up in a classroom. You talked about, and we saw the video about, even in early childhood, there's bias that is very present and has very real consequences for Black boys. And we in education know that reading, significant success in reading for students by 3rd grade is critical. And in 7th grade with math, and Black boys are significantly behind in both of those areas. So you're going through this, your entire educational career, thinking that you're behind, sitting in classrooms feeling like you're behind, and in many cases having the adults tell you that you're behind. And then you get suspended. So now you're missing instructional time because the teacher says you can't be a part of this classroom environment, but you also told me I'm behind, so I need to be there. And everything that's going on outside of the walls of the school that is very real about what I see in my neighborhood, what I see on my walk home, how I interact and engage with different family members, different people in my neighborhood, and I'm bringing all of this to school with me. That's a lot of pressure. That's a lot on the mental of our Black boys. And we also have to acknowledge, and one of the biggest things I've been trying to champion is this representation. When I was teaching high school math in the city of St. Louis, I was the only Black male teacher in my school. And our school was 98% Black, not students of color, not Black and brown, just Black. And for most of the students, for most of the students that I taught, I was the first and only Black male teacher that they ever had. But thinking about the pressures that they're dealing with, we want them to talk. And we know that in our culture, historically, we have not been able to talk about things. You talked about how we often make it a point to not talk about things. But it's even harder when we're asking them to have these conversations as teenagers, as young adults. And we often use that term young adults with them, but we're asking them to have these conversations with people who don't look like them. My teacher doesn't look like me. The counselor who I'm supposed to talk to doesn't look like me. How could they possibly understand my situation? How could they possibly have any context? The person who just kicked me out of the classroom sent me over to the counselor who looks just like the teacher. And I know they talk, and they probably have some feelings about me based on the way I look and again, the color of my skin. So without that representation, without seeing someone I feel like I can talk to, that becomes increasingly difficult. And then they don't see school as a safe place, or school as a place where they can get help. And I'll close by saying, I feel like in education and schools, we often give students conflicting messages. You talked about follow the rules. We tell them to conform. Do what we say, listen to what we say, but then we also tell them, all right, now go out into the world and be creative. Go out and don't let anyone tell you what you can't do. It's like, well, you've been telling me the opposite for 18 years of my life. I can't just flip that switch. So yeah, and it has implications not only in the school to prison pipeline and the over suspension and keeping Black boys out of classrooms, but also keeping them out of gifted classrooms. Here in St. Louis alone, in the St. Louis Public School District, Black students make up over 80% of the population, but less than 40% of the gifted school population. They're significantly underrepresented in gifted schools. And that's something that we have to address. So it's not just suspensions, but it's also what are the opportunities that they're missing out of because of the bias that exists with teachers and adults who see them differently at these early age and don't allow them to springboard into these opportunities.
Thank you to all the panelists for your comments. And I would ask all the panelists to unmute their videos so we can begin our conversation. Before we start with the questions though, Dr. Simon, would you like to respond briefly to anything that was said?
So I agree with everything, everything that was said. And I think to Adam's point, acknowledging opportunities is another key point. It's not uncommon. I have a family, and you know, kiddos doing well, and I'm like, okay, hey, it's February, so what are we doing in June, right? Because classically the things that are, you know, summer camps for basketball, for science, for ballet, right? You got to sign up not in June, you got to sign up in January, February, right? And so I start trying to ask parents, well, oh, did you know about this? There's this program called Duke Tips. Have you ever heard of that? And they're like, what is that? I'm like, okay, I'm going to send you the information because your kiddo's smart and somebody's supposed to tell him about this. I don't know why the school's not, but I'm going to tell you. And hey, let's like look up the information for it. And so my mind stretches quite often in clinic because at one time I will meet someone from the Massachusetts Division of Youth Services where I'm like, you just grew up in the wrong part of town, and because you had the same substance that a child who grew up in the suburb has, but when they got stopped, they got brought home, I'm meeting you with DYS. So I have that conversation, and then two patients later, it is wait. Your kiddo somehow is still growing like a rose, and I need to put water. I need to put, you know, good fertilizer around so that way we can keep nourishing. So I just want to emphasize the point of oftentimes we aren't acknowledging how much potential that they do have. And I love the fact that pediatrician has a part of the conversation, social work's a part of the conversation, because again, it's not going to be just one field or one profession that's supposed to be helping. It legitimately has to just be a reshaping. And again, conversation with educators, because I'm in clinic, I'm at the hospital. That's a very microscopic part of the child's life. They exist outside of the time that I'm seeing them, and it's that existence that I know is very challenging that I want to really help people as best as possible, because like you're only going to see me for 45 minutes. You got a lot of hours to exist in this world that is not very kind to people that look like you and me.
Thank you so much for your responses. So I'm going to start with some questions, and they're for all of the panelists, but if you don't feel obligated to answer every question, if you don't want to, you can pass. That's fine. So the first question is in regard to thinking a little bit about stigma, which was talked about a little bit in some of the comments that were made. So Dr. Simon mentioned in his Black Enterprise article that in the African American community, there continues to be a significant amount of stigma toward discussing mental health topics, including depression, trauma, suicide, substance abuse, and psychosis. How do we address this stigma? And feel free to kind of go around. I won't call on you.
Sure. I'll go. So there was a project, and first point, mentor anybody that has an idea related to wanting to help kids. I think we should just do that. So a student, a medical student, when I was in residency, was like, "Oh, hey, I hear you do research." I was like, "I do stuff. Like, what's your idea?" And there's a American Psychiatric Association small grant for $5,000 if a student has an idea related to disparity. And so what we did was, there's a lot of barbershop pilot programs with regards to blood pressure. Jersey, California, Texas, probably every urban city probably has had some version of this. Our flip was, oh, can we just do the same thing but talk about anxiety, depression, bipolar, schizophrenia, trauma, and see if it resonates with people? And what happened? It resonated with people. Hey, you just talk freely, and hey, you get a haircut, right? Oftentimes, I might see a patient, potentially they're stable 4 times in the year, right? Black boys, Black men are going to a barbershop way more than 4 times in a year outside the context of a pandemic. But so it's a entry point to being able to have some conversations that otherwise they may not have had, right? So when they then met me, they're like, oh, you're a psychiatrist? Yes, I am. I like basketball too. I like football too. I like rap too. And so then you're able to have a conversation in a environment that they feel very comfortable in. I recognize when I meet patients, they do not feel comfortable in the environment that I exist in because it is not created for them. A barbershop is created for them. So I think we have to think outside the box of where can we do a lot of preventive work, and it's going to undoubtedly be outside the clinical space.
There's also opportunities that family-based, the science tells us that family-based engagement and providing navigators and advocates in that space to help them navigate those more power dynamics that Dr. Simon talks about is also effective. So there are things that you can do in the clinical space with these sort of navigators added in. You know, my dean is one of those who have done, Mary McKay, she's done this work for a long time, funded by NIH. So those sort of advocates trained to help those families be empowered also helps to destigmatize or inform about the efficacy of different talk therapies or medication that really increases that family's knowledge are some things that we can do to really help those families. But again, the idea of making the clinical space one where families understand the true efficacy. Now, you're talking about Black population or Black boys. Most of the work has not been examined to see whether or not it's really efficacious with them. So part of the challenge is also they're going in there or they're having negative experiences. No one is really listening to the family, listening to the need, don't know how to interpret it or misinterpreting it. But again, there's some work we have to do as scientists. There's work that we can do to engage family support and navigators. And there's work that you can do to bring the therapies and the treatments and the support outside of the clinical setting into community settings like barbershops or Boys and Girls Club or those sort of spaces.
Anyone else? Okay.
I'll just briefly say, I think another part of it is really just normalizing it. So having your, Black pediatrician talking about mental health. An example I'll just give from our HIV clinic is, all of our patients, we have them meet with counselor on a regular basis. We say, your mental health is part of your well-being and that we want to be talking about it and normalize it. And you don't go just because you've been upset or you've expressed, feelings. We really have everyone meet on a regular basis so that, again, we can catch things early, we can help be preventative, as well as we can just normalize that talking about your feelings and addressing your mental health is something everyone should be doing.
Great, thank you. I'm going to move on to the next question, but if you want to comment on the first question as you answer the next one, that's great too. So when we think about Black History Month, we're reminded of the many African Americans who have achieved despite great obstacles. At the same time, there is a large body of research suggesting that this constant striving can take a large mental and physical health toll on people. So how do we reconcile a legacy of achievement and striving that at the same time protects and promotes health for African American men and boys? So how can we reconcile these two things? What is often seen as a stressor, depending on the research you read, but is a big part of our community and culture. And maybe we can start with Adam or our Dr. Latif.
Thank you for the question. So I would start by saying that, if we look at the context in which the Black community has developed in the US is that, one of the amazing aspects is this ability or this historical legacy of overcoming struggles and meeting those challenges. So it's really important for me in my work that we acknowledge the strength of the community. But as it relates to that reality of the pressures of meeting the challenges of systemic racism, of policies that promote white supremacy is that Black boys, and the research shows us that Black children are getting primarily an education or a socialization process that prepares them for bias. So bias socialization is a mechanism by which Black parents and caregivers prepare their children to meet those challenges. So when we see, these examples of excellence, we can see that some of this is related to those socialization processes where parents and caregivers and community members are preparing young persons to meet those challenges and still excel materially. But one of the interesting things that the literature is showing us is that bias socialization, while it is important, is mixed on the research is mixed as to whether or not this type of socialization actually bolsters well-being, indicators of positive mental health. And I say it's mixed because there's some substantial literature that says it doesn't. And there is also literature that says that in some cases, depending on the age of the adolescent and also maybe the geographical setting, that this will be helpful. However, the vast majority of research that shows that the mechanism of cultural socialization, as I've mentioned, which is the process by preparing for the world, but also the bolstering of a sense of identity, of pride, of heritage, that this is typically going to be seen less in the socialization processes that Black boys receive. Now, why is this problematic? The research is pretty clear that the benefits of socialization for adolescents, for youth, for young persons is primarily targeted within the focus on pride and heritage. So I guess to your question is, how do we reconcile this legacy of achievement? Is that it's important for us to deal with the bias socialization. I think it's as Dr. Simon mentions in his article, must he be more responsible for his actions in a way that others cannot know? The reality is, in our country, yes, he must. So this really speaks to we have to address bias socialization. But in that process of preparing Black boys for the world, preparing them for the reality of being Black in America, we cannot forget to remind them that, hey, realize you are whole, you are normal, you are healthy, you have a heritage, you have value, you have worth. You have to deal with that, but you can't internalize that aspect to believe that bias against you for factors that are truly nominal are truly an expression of your value and self-worth.
I think Mr. Lateef said it perfectly. I would just add, it's a double-edged sword for me. I think I think we need to make sure that we have support. I really value, Black caucuses within organizations, especially predominantly white organizations, to allow people of color, Black people, people who hold certain marginalized identities to be able to talk and feel supported and support each other in those spaces, which I think is very important. The other edge of that sword is, just in line with what Mr. Lateef said about that socialization, like what are the systemic impacts or systemic factors that we're reinforcing? If we know we have to work twice as hard, like Dr. Simon was saying, so if I put in 100, I have to put in 100 applications to get 10 offers, compared to my white counterparts that might have to put in 10 applications to get one offer. Is a hiring manager thinking, well, you're Black, you've always had to work hard, you'll continue to work hard, it's fine. So that's the socialization aspect. And then when we think about internalized racial oppression, at what point do we say we're not okay with that? So at what point does, the acknowledgement become, imprinted on our DNA? It's like, okay, I got rejected. It's not the system, it's just that I have to work twice as hard, and this is what's going to happen. Or if I get an opportunity that Dr. Simon didn't, I'm like, well, he didn't work as hard. And that the other side of that internalized racial oppression and the shirking of responsibility for this system, this racist and unjust system, is the part that I grapple with that question.
Yeah, I think it's a really good question, and if we take a step back, right, and like Dr. Hayes mentioned, not diagnostically anchoring, other races feel this too, right? Which is why when I'm in clinic and I have a 16-year-old or 17-year-old white girl who is beside herself with anxiety, and I start asking, oh, well, what are you doing? Oh, well, I'm on some varsity team, a next club, 4 AP classes. This exists in other races. It just manifests itself differently, right? And so there is an expectation that, oh, yes, you should be stressed. And we coach them in how to understand that stress. And so, to Dr. Lateef and Adam, as you're saying, we don't do that with our boys. And when we do, it tends to classically be in like athletics, right? So it's like, oh, Mamba mentality. I love Kobe Bryant, right? So keep working. You're not shooting with me in the gym, right? It's okay to do that in the sport world to keep going and trying to be one's best self. Yet the idea of, well, are you in the library for another hour? Did you do another 100 questions? That same conversation isn't had. So oftentimes when I'm with my students, and I'm speaking to medical students, I'm trying to explain to them like you're just as capable as your colleagues, like because we often do this. Grit is a very good book, highlights this, right? We tend to overemphasize like the one-offs, right? To say, oh, Dr. Simon did this thing, and so people then say, oh, like attributing things to me that are not true. I'm like, look, I wake up, put my shoes on the same way that you do. You're more than capable of doing it. So I think there is this mythology that we do in Black culture, which is why we can say, oh, certain people, Beyonce, LeBron, right? We emphasize them, but it's like that's too high of a bar to say you have to meet that person. You are just as good as you are, and you can excel with what you're doing. So Dr. Lateef's point regarding the socialization is very important.
I'm just going to add in that this concept of working twice as hard in the Black communities, we refer to it as John Henryism. And a couple of years ago, we had Sherman James come in and speak about that. And it has really direct effect on your heart, your health of your heart, how long your body perceives you've been alive, meaning it ages you. So this is another compliment to what colleagues are saying and how it's important to acknowledge it. But at the same time, we got to create a new deal for Black boys in America. The Black male body went from being one of high commodity, as August Wilson said, to being one of being thrown aside, of no value. And so we have to create a new deal that attends to how Black boys are experiencing America today, that will lead them to feeling not only opportunities for hope, but support as they're moving through the opportunity structure, and to be as healthy as possible, both emotionally and physically.
And Edie, I believe it might have been to the last question. Dr. Constantino wanted to say something.
Sorry.
I have a wider screen, so
I'm trying to field all the questions, so I'm not always looking at people. So I'm sorry, Dr. Constantino.
Not at all. I'm not going to derail this. I was going to ask Kevin and Adam to comment on, because Kevin made this comment about the sort of compartmentalization of child psychiatry, that even though he's doing these magnificent things to advocate and for the community, that he only has an hour in this life or whatever. And I'm curious what he and Adam think about the disconnect between the medical environment and education. Oftentimes, we try to get our doctors to conference call into education plans for special needs students because we have to get the whole team together. And, how to pull, this is an area where there's a lot of fragmentation in what could otherwise be a lot of support. And we've really seen this play out in kind of really unfortunate ways with families.
Yeah, I would agree. Unfortunately, the mechanisms for a clinic or a hospital is just not conducive to trying to schedule things, and doctors are just often late to the 2:30 meeting that we said that we're going to be at 2 weeks ago. I think,
and you don't get paid for it either. Like you can't get paid for that. No one can get paid for that. So it doesn't happen. There's no structure for it.
Right. So I do think much like, there's work, in the collaborative care model field with regards to primary care. If there could be some new structure with regards to financing, collaborating with school systems, that's something that, yes, currently does not exist. And if you are going to bill it, you're billing the family, you're not billing the system. So it's a very challenging part, because you want to be there. Your voice is important as the clinician to say, oh, this is a conversation that you're having, because you guys see them 5 days out the week. I see him or her 1 day out the month. So somehow we do have to figure out, and perhaps this is like an insurance question or a state Medicaid, like we have to figure out how do we, monetize that time that is critical.
And I would just add that, that connection is critical, and we don't prioritize it. And I would say, especially in public education. I remember when my first day as a teacher, I didn't even realize this. I went to public education in Boston up until 4th grade, and then private until 12th. And I didn't realize that my classes were back to back to back to back, and then the day is over. So in bringing up the conversation of having more mental health professionals in schools, it's not just about having more, but it's about completely revamping the system, the schedule, and the prioritization of mental health within schools, so that students actually have time. If we had 100 mental health professionals in a high school of 100 students, and they're going from class to class to class to dismissal, they'd never have an opportunity to have a meaningful conversation with any of them. So yeah, it's a systemic approach, and we have to, it's not prioritized, because in public districts, it's what are the academics, what are the scores, are they going to school, what's the attendance, and how much money are we spending on them? Mental health, their health in general, hardly comes up in that conversation around how do we build our budget. And what do we report out to get our funding? And if we can change that narrative, we can place a stronger emphasis on it.
Thank you. So I'm going to ask, I'm going to combine two questions. One that is actually John's question with another question that they go hand in hand. And so, and this was also discussed by many of you, but the criminal legal system, from policing to incarceration, has exerted great harm to African-American men. Systematic racism is evident at every stage of the system, and the racism inherent in mass incarceration affects children as well as adults, and is often especially punishing for Black boys and men. We know, for example, that 1 in 1,000 Black men and boys will die at the hands of police in their lifetime. And so how should we think about Black boys' mental health in relationship to this system? And before you answer, John also mentioned that we should be, when we're examining these cohort effects that were talked about, where we see this divergence of white versus Black adolescent suicide, as well as this 5-fold acceleration in incarceration of Black boys who drop out of school. Both of these are relatively recent phenomenon. So he was also asking if you wanted to comment on that relationship. And John, you're on the panel right now, so you can also further discuss, what you were thinking about there too.
Thanks, Eddie. I was just blown away by it, like that those trends are so recent in terms of the divergence in boys, and Sean talked about this, but the divergence in boys suicide, Black versus white, boys suicide, and that how that's diverged. And at the same time, this very recent acceleration for boys who have dropped out of high school. It's it's a relatively recent phenomenon, in that we've gone from 10% to 70% likelihood of incarceration. Like, what is the connection between those? And if it would be great to talk about that.
I also, before you respond, I just wanted to thank Sean Joe for being on the panel. He has to go to another panel at 6 o'clock on the dot, but he wanted me to send his apologies. Curious. Okay, bye.
Yeah, so it's a really good question. And although he just left, he mentioned the idea of family-based intervention. So, unfortunately, we're going to have to, again, address this holistically. And so recently, in reference to funding, I secured funds to try to do a family-based intervention for justice-involved youth. Long-term goal is to try to decrease substance use disorder, and then obviously recidivism, because there's a high recidivism rate for those that are involved. I think this is where so John has a whole division, right? Like, I would posit, are you in the St. Louis or whatever the Department of Youth Services is in the St. Louis County area, right? Is there a relationship there, right? That relationship helps youth who undoubtedly oftentimes don't get services. That's so you're working on the back end, okay? On the front end, okay? What is the relationship in terms of with the school system, right? So St. Louis public school system, what conversations are we having? In terms of meeting parents, right? What kind of conversations are we having? So I tend to think about things in systems, and so it is, yes, very frustrating to know that we have to do so many things at the same time. But I think there is a connection that has not been yet well described, that yes, increasing the rate at which your life is going down this path that's not ideal, and the society that I exist in is not ideal. When you're in a pressured situation, you make a very impulsive decision. And I think that is the decision that we're seeing in terms of youth committing suicide and completion at a very staggering rate. Because, when I read the data, when I read Coates's book, Baldwin's book, right? Baldwin himself had a suicide attempt. The environment that we exist in is just not well suited for our being. I mean, just everyone knows that there's a Texas is having a winter snowstorm. 18-year-old black boy walking home from Walmart where he works, arrested. It's like, he's walking home. Well, why don't you bring him home, right? Well, we got a call, you don't have a jacket on. Well, he probably doesn't own a winter jacket. You guys are in Texas. No one knew it was going to snow, right? So when I was in residency, what did we do? Our child psychiatrist, who also had training in forensics, she started to have us give lectures or didactics to the police division, right? I don't actually know if the lectures were helpful or not. However, hopefully they were, and at least being able to have a conversation with, this is what anxiety looks like in people of color. This is what depression may look like. This is why substance use might happen, right? So, because again, a field that's not engaged here is law enforcement. They exist. They're going to continue to exist. We have to somehow be able to engage with them and have a conversation with them. So my grant is, I have to have a relationship with these folks, that I have to help them see, hey, you're taking a lot of people who are Black and brown, and they're in this environment. It is what it is. Let's fix it, right? So there's a lot of ways that we have to come at this. And I'm just talking, so I'm going to stop myself from talking. But yeah, this is it's very problematic.
So before others comment, I just want to ask, to add to this, a question that came from the audience as it relates to this. So we're a research institution. What kind of research needs to be conducted, right, around these topics as well as we talk through these issues? Anybody else wants to comment?
I just kind of want to continue off with Dr. Simon shared and also discussed earlier, is that, one of the benefits of this discussion, but when we think about, I think, particularly this question around the intersection between the experience of Black boys, young Black males, and adult Black males with the criminal justice system, it's an interdisciplinary concern. and no one discipline alone is going to be able to really tackle it. So it really, begs to the question that we need to find ways to ease that relationship to be able to do the work that's necessary. But a couple of the questions that, in the process of when we think about the criminal justice system, in my social work practice is focused on reentry with juvenile lifers, our adult offenders spending, substantial time while incarcerated, is that thinking about what to do depends on what stage of their intersection or the relationship with the system is. So are we thinking about prevention? Is it a situation where the young Black boy hasn't had interaction yet? So are we thinking about prevention? Are we thinking about what's occurring at the time of sentencing? Are we thinking about how the time of the young Black boy or the young Black male, in this case, if they're in the adult correctional facility, what is their experience during that process? Are we thinking about how are they being treated when they go up for parole? What's the experience while being on house arrest, general parole? Are we thinking about once they're absolute discharge? These are all different points at which we have to think about, and the approach is going to vary. But I would also say really where there's a deficit to really answer these questions, and there is a need for more research, because unfortunately, most of the research that we can see about this issue has not yet been able to go beyond explaining that there is a disparity. It hasn't been able to go beyond thinking about risk. We have to think about what are those protective factors for this population. We have to think about what are those resiliency factors for this population as well. And so there's a lot of room for the need for additional research around the topic.
Thank you so much. We're getting towards the end of this amazing panel, and I wish we could talk more and more, but we want to leave a little bit of time for Cherie Wilson to give final comments. But I didn't know if anybody had any small thing that they wanted to say before we transition to the end of this wonderful and important conversation. Especially Dr. Simon, if there's anything else you'd like to say.
Yeah, no, so I wish we could continue the conversation, and I really do appreciate the fact that you all invited me. And I think the work that's happening at WashU is important, not only just for St. Louis, but really for the nation at large. And so, just thank you for having me.
Thank you so much. So I'm going to turn it over to, thank you everyone for participating on this panel. Thank you so much for a wonderful talk. And I'm going to turn it over to Dr. Wilson now for her final remarks.
Great. Thank you so much. Thank you, Dr. Lee. I'm Cherie Wilson. I'm the Associate Vice Chancellor and Associate Dean for Diversity, Equity, and Inclusion in the School of Medicine. And I first want to thank Dr. Constantino for bringing Dr. Simon to our attention here in the Dean's office. This has been an excellent, excellent experience. So thank you so much. Thank you to all of the panelists. Dr. Simon, you raised a number of different topics that, especially when I think about the work we're doing here in the School of Medicine, around understanding systemic racism. As a matter of fact, I was being texted by our Director of Programming and Professional Development, who's leading this, saying, okay, we have to incorporate this in. So you certainly have raised some additional topics for us that we will be incorporating. You raised, and I certainly don't want to reduce this to quick sound bites, but you did raise a number of topics. There was a lot of discussion, obviously, around the high suicide rate. That was new for me. I was not aware of that, and certainly very jarring. I also like the way that you framed rapping as journaling. And again, I think we don't often think about that. Often the first reaction is rapping is bad and that is negative. And so I like the way that you've taken so many of these different aspects and help different individuals to think about what's happening in ways that are very positive versus immediately sort of condemning Black boys to negative kinds of behaviors, because we know obviously the results that can come from that. So again, I want to thank you so much. I thank our partners in the center and CRE too for their sponsorship. And again, thank you everyone for your participation and for coming to tonight's event for Black History Month. So thank you.
Thank you.